A very good morning to all my dear friends. Today we are going to discuss about anaphylaxis in our critical care micro teaching class. I'm Dr. Dharanindra. I've done my MD in anesthesiology and DM in critical care medicine, and I currently head the intensive care unit at Ramesh Hospital, Vijayawada. So, anaphylaxis is a life-threatening emergency. If you want to do a rapid overview on the emergency management of anaphylaxis, we start with identification of the symptoms. After any known trigger, like a blood transfusion or like a fresh frozen plasma transfusion or any other blood products or antibiotics or any other substances which a patient is known or unknown to be allergic to, if the patient develops symptoms like respiratory distress in the form of presenting as stridor, wheezing, dyspnea, increased work of breathing, persistent cough, and cyanosis, and also cardiovascular symptoms like hypotension, arrhythmias, and cardiovascular collapse. All these symptoms constitute life-threatening anaphylactic reaction. And the initial management in any anaphylactic reaction is try to isolate the patient from the trigger. If it is any transfusion of blood products, stop the transfusion. And the first line of management is epinephrine. Epinephrine ideal dosage is about 1 is to 10th of the cardiac arrest dose. So if you are giving 1 milligram in a patient with a cardiac arrest, you have to give 1/10 the dose. That is, if you dilute 1 ml, 1 mg in 10 cc, it is 1 is to 10,000. And you can keep giving it intravenously in allocates of 11111 cc until you see a response or transient improvement of the symptoms. So the indication for IV epinephrine administration is very clear. It is cardiovascular and pulmonary symptoms of anaphylaxis. Cardiovascular include hypotension, cardiovascular collapse, tachycardia, and respiratory symptoms include laryngospasm, bronchospasm, which are manifested as laryngospasm as stridor, bronchospasm as wheezing, and they can present with dyspnea, increased work of breathing. Okay, for all these symptoms, epinephrine intravenous is the treatment of choice, and there are no absolute contraindications to epinephrine. Apart from this, airway management in the form of endotracheal intubation should be done in a double setup model. So the first part of the setup is conventional attempt at endotracheal intubation and followed by a backup safety mechanism like front of neck access, like cricothyroidotomy and tracheostomy. And you should also remember that after airway and breathing management, you have to continue epinephrine infusion to maintain the cardiovascular status and maintain mean arterial pressure. Apart from this, the patient will also be hypovolemic because of increased vascular permeability and venous dilatation and dilatation of the capacitance vessels. So for vasoconstriction, you have already started epinephrine, which has a good alpha 1 action. And at the same time, you have to fill the plasma volume which has been lost due to leaky capillaries. You have to fill it with crystalloid solution, and ideal is a balanced crystalloid. You can also start with normal saline, and you can continue with the balanced crystalloids like Linger acetate, Ringer's lactate. After IV fluid resuscitation and adrenaline and airway management, you also have the role for corticosteroids, and we also have the role for mast cell degranulation inhibitors like chlorpheniramine maleate. Okay, so I always want to emphasize over here that the role of steroids, the effect of steroids will take time to occur. It will take at least 2 to 3 hours to come in shape. Until then, the drugs which are going to save the patient and tide the patient over the crisis are epinephrine, IV fluid management, and airway management. There are some patients who are taking beta blockers. In these patients, if you don't get adequate response to epinephrine, you can add glucagon 1 to 5 mg IV over 5 minutes, followed by infusion of 5 to 15 microgram per minute. Okay, this will improve the response to epinephrine. At the same time, I want to tell you that anaphylaxis is a life-threatening problem, and it is often underdiagnosed, and the magnitude of the problem is underestimated. So be prompt in diagnosing and always be judicious and use the correct route of administration of epinephrine. If the patient is having cardiac and pulmonary symptoms, please don't hesitate to give intravenous epinephrine in a diluted form 1 is to 10,000. If the patient is having a cardiac arrest, follow the BLS and ACLS protocol. If the patient is having a milder reaction in the form of urticaria and hives and flushing, you can give intramuscular dose of epinephrine. When the hemodynamics are stable, you can always use the intramuscular dose. Intramuscular dose should be given at the lateral part of the thigh, intramuscular. Thank you for tuning into 5 minutes or micro teaching and critical care medicine. Myself, Dr. Dharanindra. Until next time, see you.